But just to get us started and to show you that, I will start my share. If I can do it correctly, right? So this is actually the timetable. But if I move across to another screen, so this is the Leeds Virtual Pathology website, which I'm sure many of you are aware of. There's the title at the top there. I'll maybe put that in the chat. It's quite difficult to maneuver on many different screens. But just when we get us started, I'll open a chat preview, and then I can manage these things all in one go. So, Ava, I think I need permission to send this to everyone. I can only send it to panelists and the host at the moment.
You should be able to now.
Okay, let's just try it again. It's just saying panelists and hosts for the chat.
Maybe try it again.
Yeah, let me just maybe close it down and start it off again. Everyone, great. Thank you very much. That's great.
Yep.
Okay, so this is a really good resource, the Virtual Pathology Leeds website, and in particular this EQA set within it. So when you go to the homepage for the Virtual Pathology website, you get this. When you go to the EQAs, you will get this, and this one here, the British Lymphoma Pathology Group, is a really good set of EQAs. Now, some of the older ones, will have the diagnosis as well. So for instance, I think this one shows the diagnosis. Many of the more recent ones, I'm afraid, just have the slides, and this is the one we will be using so far, around 23. Also within this set, there is, if you go to the slides, sorry, if you go to the slides, no, let me just find it. Teaching, yeah, teaching. And then the postgraduate sets, there is this set here, Dr. Heba Ali Haematopathology Atlas. This is relatively new within the EQA set, within the Leeds virtual platform. And there's a huge range of digital cases, and I will show some of these today. Just to give you a flavor of this. And I think from today, I'll use today as a bit of a springboard to start using these interspersed with mitrofines on an alternate basis to give you more lymph node exposure as well. But it's a fantastic, the Dr. Heba Ali Heme Atlas is a fantastic resource. So again, I'll just specifically link that in the chat. And the BLPG EQAs, which are particularly interest to you for Hempath. That's the EQAs. And there are also many other EQAs within this. So for instance, we've got the Northwest of UK EQA. There are neuropathy EQAs, GI EQAs, head and neck EQAs, really, really extensive set of material here. So, I advise you to use this for lots of learning. I find it's almost completely comprehensive. It's very easy to navigate. It's completely free. It's based in Leeds, which is in Northern England. And it's really fantastic. You're probably all aware of it. I don't know if people can just raise their hands how many are aware of it or not, out of interest, before I proceed to what I was going to talk about mainly today. Yep. Okay. So we've got one person, two people. Great. So I've managed to spread the news for another 16 people. That's good. Right. So without further ado, we will look at what I said I would do, which is this EQA. So I've just done round 24, but round 24 was for the EQA members and is not yet on this website. No, it wasn't actually. It was round 22 I was going to do. Yeah, round 22 I'm going to do. Right, so I need to get my screens together. Right. So I'd like to be good to have some audience participation in this one. I'm going to ask questions and answers. Again, nothing, don't be shy putting your hands up and volunteering answers. We'll start with the first one. This is a 58-year-old male, possible liver mets on imaging, no known primary, and he's got a right lobe of liver core biopsy. And this is the core. You can see it's got two duplicates. At low power, it doesn't look like much in there, but we'll look at higher power. And at higher power, we can see these nodules appearing within the liver, quite discrete nodules. The rest of the liver architecture actually looks reasonably good. Maybe a little bit of vacuolation, a little bit of kind of change in, and tiny bit of cholestasis there in the cells adjacent to these nodules. And I think there may be, got a little bit of cholestasis in the liver, spread around. Some of it's next to the nodules, some not. So there are multiple nodules spread through the liver. They don't look like carcinoma. Of course, this is a lymphoma EQA, so you wouldn't expect it to be carcinoma. So we're expecting a hematological condition, and it may be either reactive or neoplastic in the EQA. So just looking around here, are there any comments from the audience as to what they think this would be? So the way the EQA works is that you you're given the H&E virtually, you make some comment on it, you request some immunos, and then they give you the immunos that they did. So once we've had some comments on this, we can go and look at the immunos and then hopefully get to the diagnosis. So any differentials from this from anyone? No? Anyone want to stick their neck out? Put anything in the chat? Oh, okay. Portal. So you've got portal based. So you've got eosinophils and lymphocytic infiltrates. That's really good. I don't know, Ava, if you're able to unmute people. People might want to talk instead. I don't know how easy that is to do.
I think they will come up as panelists, so I'm not sure if I can do that.
Okay, fine. Right. So this is an extremely good answer from both. So you got LCH. So what do you mean Nengu by LCH? Can you just spell that out?
I can try to unmute and see what happens if someone does want to try to talk. We can test
Okay.
that.
Yeah. So we've got Venkatesh suggesting Hodgkin lymphoma and Nengu suggesting LCH. So I think that Venkatesh, I think you're absolutely right. And you're absolutely right. Hodgkin's needs to be ruled out. I think the presence of eosinophils also makes you think possibly of a T-cell lymphoma, and that can also have histiocytes in it as well. I'm just wondering, LCH as a diagnosis, what were you thinking there, Nenku? Just as I can't quite see exactly which. Langerhans cell, very good. Okay, yep, that's a good one too. Um, I'm not so sure about the eosinophils, but I think that both of you are really spot on. I think that with this appearance, you have to have a wide differential. I also included T-cell lymphoma within it as well. But certainly when you see histiocytes, always think of a Langerhans cell. The present EQA actually did have a Langerhans cell histiocytosis in it. I'm not sure this is, but as you've both indicated, it all comes down to the immunos. So let's look at the immunos. Looking through this, it's a very mixed pattern of inflammatory cells together with eosinophils, very histiocytic, lots of kind of foamy histiocytes. Not much in the way of large cells. There's a large cell here, maybe a large cell here, maybe here, but not much, certainly in this nodule, not much in the way of very large cells, and that there maybe there as well. But the immunos, if we look at the immunos, we were given a CD20. This is negative. And I'm just, reiterating the point that when you don't see a lot, always look for the control. You would expect that as they've put it in, this will be a positive, but you should always look at the control or try and find some positive cells. I think that is a lymphocyte there. CD3. So, I wondered maybe T cell. I don't think this is a T cell lymphoma. We haven't got sufficient infiltrative T cells. The T cells seem to be quite small, whilst, well, we know that in the actual lesion there are some larger cells. So if it was T cell lymphoma, and that can quite often have a very wide range of differentiation of the cells from small to medium to large. But obviously, if it was a T cell lymphoma, the large cells would also be positive, not just the small ones. They've also given us CD30. And this is positive in the larger cells. So it's a lot positive in larger cells. And they also gave us some additional information, which I will just put into the chat so that people can see it clearly. So they were CD15 positive. They were CD45 negative. That's leukocyte common antigen. And they were 79A negative. So we know they're negative for classical B cell markers, but weakly positive for PAX5. And this is the CD30. So CD30 on its own does not make a diagnosis of Hodgkin's. I think CD30 with CD15 is almost certainly Hodgkin's. And if you get weak PAX5, then that is very characteristic of classical Hodgkin's disease. Now, if I go to, I'm just going to go to Hiba Ali's set and see if I can find an example of a classical Hodgkin's with PAX5 with PAX5. So if we look for let's see if we've got any with PAX5. Yeah, here we are. So there's a good example of PAX5 in Hodgkin lymphoma. So PAX5 is a B cell marker. And as we know, Hodgkin cells, well, Hodgkin is actually, it's under the umbrella of B cell lymphoma now in the classification. But there's a really good stain for Hodgkin's because you've got weak positivity in the larger cells and strong positivity in the small lymphocytes. Okay. So the combination of the weak positivity in the larger cells, here we've got weak positivity, strong positivity. And if you've got, I mean, not all cases of Hodgkin's, but most cases of Hodgkin's will be negative for 20, and the proportion might be positive for 79A. But if you've got negativity for 20, and most are negative for 20, there may be a small proportion of said positive for 79A, but they will usually be negative for 20. So they're obviously aberrant B cells. But if you've got an asynchrony between positivity for PAX5 and negativity for CD20, then you know you're looking at Hodgkin's. because it's the crippled kind of immunoglobulins, which mean they don't express CD20. And you can see the difference in staining between this dark staining in the infiltrating lymphocytes, which is positive controls, and this negative and this weaker staining in the Hodgkin cells, this Hodgkin cell here. Now, of course, within the case that we have had, it might be more difficult to do that because CD20 was almost completely negative. Yeah. So you wouldn't have got a lot of internal positive control in this case to distinguish the weak staining. Right. So Venkatav, how to differentiate Hodgkin and peripheral T-cell lymphoma with RS light cells. So again, I would say that's going to be on the basis of immunos. I don't think you can do it reliably on H&E alone. I think, because T-cell lymphoma can also have infiltrating other inflammatory cells, just like Hodgkin. So I would go, I think that probably the one immuno we'd use is you could use a CD3 and a PAX5. I think very rarely Hodgkin's can be negative, it can be positive for CD3. But yeah, I would use 15, 30, and PAX5. But 15 is not always positive in Hodgkin lymphoma. 30 can be positive in other things. Some Hodgkins are rarely positive for 20 or 79A in a proportion of cells. The one thing as time has gone on that I've found to be the most specific marker is in fact PAX5 and the weakness of PAX5 compared to the internal positive control B cells, which are strongly positive. Okay, well, we spent quite a lot of time on that case. Are there any more questions from that case, which I think is a really interesting case? And I must confess that when I saw the H&E, which is here, Hodgkin's actually wasn't on the top of my list. So Venkatesh, congratulations. That's a very, very good suggestion. But also, Nengu, thank you for suggesting Langerhans cell histiocytosis, because I think in a case like this, it's really important to have a wide differential and think what immunos am I going to use to sort it out. Right, let's look at case 2. We're not going to get through them all at this rate, but any more questions? Let me just stop and take any more questions. Have we got a question from anyone in the chat or anyone wants to speak? I don't know, Ava, if anyone's able to speak or not. Oh, okay. Yeah. So we've got a question and answer and a webinar chat going on. So I've opened both little boxes so I can see them. Okay, everyone happy with that case? I think it's important to a lot of things I've said is because quite often you get needle cores of Hodgkin's and diagnosing Hodgkin's on a needle core can actually be quite difficult. Right. So the next case, close down some of these windows so we don't have too many going on at the same time. So a female, 29 years old, and right level 4 neck biopsy. Right, so we've got one nice good core. Even at low power, it looks a little variable. We'll look at it at higher power right the way through. We'll start maybe at the top and go to the bottom. And I think this is a really good case, actually, and something you don't often see. Can you all see that well? Yeah. So we've got, yeah, great. Thanks. If I do that, does it cut part of the screen off or not? Or can you still see the same thing? If I move that you can still see the whole thing? basically I'm shrinking it to fit my screen. I just wonder at the far end, does that affect what you see? You can still see the whole thing. Okay, right, great. So what we've got here, we've got lots of lymphoid cells, no particular architecture. Um, Looking down, we've got this area here with some kind of nuclear dust and debris in that area. And we go down here, we've got another area of fairly large, slightly atypical lymphoid cells. And we go down the biopsy, we've got more of this, no particular architecture that I can see. Again, another slightly necrotic area with lots of these karyorectic cells and lots of bits of nuclear dust and debris. Carry on down the biopsy. Again, lots of larger kind of transformed cells with prominent nucleoli and lots of small lymphoid cells in the background. Again, another area with this nuclear dust. Okay, so we've got a very good suggestion there from Takesh of lupus lymphadenitis. So I think that's a really good suggestion, actually. Um, Let me just hang on a moment. Sorry, I was looking for one of my older textbooks because I wanted to look up lupus lymphadenitis. Um, so we've got Venkatesh, thank you very much once again. Lupus lymphadenitis or Kikuchi's. So I'm not quite sure about the how you distinguish lupus lymphadenitis from that. Um, because I think those are the two main differentials. Um, yeah, the fibrinoid necrosis can suggest lupus, but I think that all the karyorectic debris is probably more in keeping with Kikuchi's. We've got immunos for this as well, which are also characteristic of Kikuchi's in this area. So looking through the microscopic features of lupus here, you get florid follicular hyperplasia and paracortical hyperplasia. You do get these immunoblasts, which we've got here. I'll come back to these in a minute. You can get nuclear dust, and we have got that. Yep, again, you're very right there, Venkatesh, and we've got the MPO, so I'll show that. So we've got MPO in Kikuchi's. I think you're more likely to get a bit more maybe follicular hyperplasia in lupus lymphadenitis. Of course, you would want a history of lupus, though this may be the first presentation. But you can get follicular hyperplasia remaining in Kikuchi's as well. So that's Kikuchi's. Yep, and more plasma cells will favor lupus. You're right. Okay. So let's go back to the case and let's look at that. So let's look to see if we can find any plasma cells. Well, at this power, actually, there are some plasma cells in here, actually. There's some plasma cells here. But I think, again, these cases, it's really important to give a, differential. Kikuchi's it can be a trap for the unwary because there's often a lot of T cells in it, and the transformed immunoblast-like cells, these large transformed cells are often T cells. So it can be to the unwary, it almost looks like a high-grade lymphoma because you've got necrosis, apoptosis, and large T immunoblasts. So, but I think if you see this kind of necrotic areas with all this karyoretic debris and nuclear dust, plus these florid large areas of immunoblasts, which look really, on their own, these look really quite nasty, then I think Kikuchi's is more likely. And I think it's also more likely to be unilateral than lupus. So let's go to the immunos for this case. CD20. So the architecture has been, largely effaced actually by this infiltrate. And we've got a range of CD20 positive cells, some quite large ones actually, and lots of small ones. But no, we haven't really got anything in the way of residual reactive follicles. CD3. So CD3 very strongly positive through it. Let me just wait for it to unpixelate. And you can see many of the large cells are positive for CD3. But again, it's a range of cells like the CD20. Now CD123, this is a useful marker, and this is expressed in plasmacytoid dendritic cells. So this is characteristic of Kikuchi's, these CD123 positive plasmacytic dendritic cells. Okay, so we'll come back to those in a minute. So, and they are around or close to the areas of necrosis. And then also, as just going to the end of the chat there, we've got myeloperoxidase positivity as well. Okay, a bit weak to be honest. It's difficult to say whether that's positive or not, in fact. A lot of that could be hemosiderin. I think that's hemosiderin. I think myeloperoxidase here is negative, largely negative. It's very, I can't really see high enough power to say whether that's positive or not. Yeah, I think it is positive. That's positive for sure. That's positive. Some of this is background debris, but there is some positivity for myeloperoxidase. We've got some positivity here and here. So if we go to the blue book, no, not Rosai-Dorfman, Kikuchi's disease. I think this is Kikuchi's. What do people think about this one? Do they think it's Kikuchi's or lupus? So the other thing we've got is we've got lots of histiocytes in the necrotic regions, and the large cells are positive for the large cells are positive for CD8. So this is Kikuchi's. So lots of karyoretic debris, proliferative phase with abundant debris. There's often lots of immunoblasts, and then you can get coagulative necrosis later on. And plasma cells are scarce. There are plasma cells in this case, actually. Frequently express CD68 and 163, which we've got, and myeloperoxidase. And CD123 is also positive in the plasmacytic dendritic cells. So who thinks this is what votes have we got for in the chat, please, for either lupus or Kikuchi's? Who thinks Kikuchi's? Okay, most people are going. And don't just say it because I think it's Kikuchi's. I do think it does look more like Kikuchi's than lupus. But the clinical history would have to be considered. Yeah. Okay. I think that's an interesting case, and I think it's a really instructive case for people who are less experienced. And of course, I include myself in that in the past. It is a really easy, particularly where it's very florid, to mistake this for a high-grade lymphoma. If we look at Dr. Hiba Ali's set, she's got some examples in her set. We go back to her. She's got some Kikuchi's in this one, so we can have a look at another Kikuchi's. So there's another example of Kikuchi's. I mean, here we have got a few residual follicles, but like this one, most of the follicular architecture has gone. Yeah. I don't know if she's got any lupus lymphadenitis. Let's see if we can find a lupus lymphadenitis. Yeah, there's an SLE lymphadenitis. So this one here, you can see the difference here. We've got a lot more reactive follicles left. Whereas if we look at the Kikuchi's, the architecture's a lot more gone. We've got a little follicle there. But the rest of it, there's huge areas of very abnormal cells, very atypical immunoblasts, lots of karyoretic debris. If we look at the lupus case, yeah, we've got some. It's not again. It's just that the necrosis is not as florid, and there is some residual reactive follicles left. She's got other examples of. She's only got one example of that. She's got other examples of Kikuchi's, and here normal architecture's gone. So I think that is kind of a clue as well. Okay, we'll move on to case 3. Are there any more comments anyone wants to make about those? I think we had a difficult diagnosis of Hodgkin's to start with, a wide differential, and we had a long discussion about Kikuchi's versus lupus, but also, very important to consider that what you see is not neoplastic, that could be reactive. And I think another clue in this woman was the fact that it was, an enlarged neck node in a 29-year-old. It'd be unusual for a high-grade T lesion to be, in a single place. Any other comments before I move on? Next case, a bit more straightforward. No? All happy? All not happy? Speak now and forever hold your peace. Okay. Right, we'll go on to case 3 then. So, 78-year-old. So this is a video-assisted thoracoscopic biopsy of pleura. He's got a persistent right-sided pleural effusion. So I have no idea what caused this effusion. Could be mesothelioma, could be carcinoma, metastatic carcinoma, but it's a persistent effusion, so they have taken a bit out. And what we've got is lots of pleural tissue. Of course, I'm not an expert in cardiothoracic pathology, unlike my colleague from last week. So it all looks the same to me, except obviously there are lymphoid cells here, and it is in a lymphoid EQA. So we're thinking that this might be some lymphoid lesion. So we have this monomorphic infiltrate of small, kind of regular, really, almost slightly irregular, but small uh, lymphoid cells, and they're scattered all the way through the biopsy. Any ideas from the H&E what this might be? I think this, and there's probably more to say to this than meets the eye, actually. It looks relatively straightforward, but there's quite a lot to say about this, actually. A good teaching point. And I've got a real case of mine to go through alongside that, actually, to make the point. So what do people think of this? What do people think this is? This is a good field here, actually, just here, with some small, slightly irregular cells and some, not many, but some larger cells. So just checking. Okay, I think Venkatish, I think your answer is great. A low-grade non-Hodgkin lymphoma. It's always important to be correct. So yeah, I think it's low-grade NHL. Okay, Jay says query CLL. Uh, Ava, were people able to mute speak or not? I can't recall whether that was a possibility.
I
Anyone?
can try if someone doesn't want to speak. I can see if I can allow them to.
Yeah. So Jay, would you like? Are you happy to speak and say why you think it's CLL? Or you can type in why you think it's CLL. And any other answers for what people think this is. So we've got low-grade NHL, which is quite a wide range. Okay, small size with coarse chromatin. Correct. Yeah. They're small, football-like cells. I think that's a really good answer as well, actually. Yeah. Okay, not able to access my, that's fine. Right. So when you see small little cells like this, which are all very regular and all look the same, largely, whether they look like footballs or slightly condensed chromatin. So dense chromatin, and they're all small, then CLL is a very strong possibility. The other thing it could be is mantle cell lymphoma. The other low-grade B-cell lymphomas, and I would include follicular in that, but follicular, marginal zone, a lymphoplasmacytic lymphoma, I think they're the main ones that I would consider. Can't think of anything else off the top of my head. It's quite a small group, actually, in terms of common diseases. Um, they will have a range of differentiation of these cells, including centrocytes, sometimes centroblasts, immunoblasts, paraimmunoblasts, um, plasma cells, plasmacytoid cells. And that will be the case in marginal zone and in lymphoplasmacytic. Obviously, follicular will be centrocytes and centroblasts, but the uniformity of these cells will be different in those other low-grade lymphomas. The main differential of CLL is mantle cell. CLL often has some larger cells in it. I think in this one you've got to hunt a bit more for the larger cells than normal. They're usually a bit more apparent. Whereas mantle cell is almost exclusively just small cells. And if you see any larger cells, you should doubt a diagnosis of mantle. So mantle is all small cells. So if we look at the immunos for this one, we've got CD3, which is largely negative, some infiltrating T cells. CD20, which is strongly positive everywhere. So yes, it's a B non-Hodgkin's lymphoma. They're often differentiated into CD5 positive or negative. I think this one is CD5 positive. It's often important to look at high power for CD5. This is a really strong example, but sometimes the CD5 is quite weak. So if you look, for instance, here, that very dark cell there is probably a T cell, and that one there, and that one there. And these weaker ones, including these, and these, are the CLL cells. So imagine if all of them are like this kind of paleness, then if you look at low power, it can look negative. So you've always got to look at high power, and you've always got to see some a really dark residual T cells in it. 23. So CD23 is classically positive in CLL, though not all CLL is positive for 23. And the one stain they haven't given us is cyclin D1. So moving on to another case, which is a live case that we've got ongoing now. This is a man born in 1957, so that makes him coming up to 70, 68, I think. And we've got his, I'll have to do another share. So, right. So this is his Trifine. And it's a really interesting case, this. So let's get in focus. Let me just do all the writing it. So got quite a good Trifine sample. I'll give you his full blood count. So his hemoglobin is 137, platelets 160, neutrophils 4.5. So normal, really. And looking through, you've obviously got areas of infiltration, like there. Let's see if I can get a better auto whiting. Yeah, there. And up here, up here. Now, if we look at one of those areas in detail, say, for instance, this one, we can see what the cells are like in the area. All right. So what we've got, that's a really interesting case. We've got lots of largely small cells. Though in fact we have got some larger cells, like there and there and there. So morphologically, this does actually look like CLL. You know, a background of small cells and then occasional larger cells. In contrast to the last case, I'll just show you the immunos for this one. This patient had some flow cytometry done with flow markers, immunological flow markers in 2021, and he was said to have CLL. He's come back with a couple of recent biopsies which showed some slightly atypical cells, and the flow cytometry, which does not include cyclin D1, was reported as a CD5 positive B-cell non-Hodgkin's lymphoma. So obviously that includes CLL, mantle, marginal zone, lymphoplasmacytic. And the aspirate said some slightly atypical cells. And what we have here is we do have a mixture of small, slightly irregular cells, football-like cells, like we've just seen, and these larger cells. So when we do the CD20, you can see that it's very extensively infiltrated. That's the control. If I can find the thing there. So really, really heavy infiltrate all the way through. I thought maybe 80% of the cells. Okay, that's a good point. Natasha's query. I don't think it's Richter's transformation, because where you get that, you get sheets of blasts, but they could well be pro-lymphocytes. Yeah. That's the CD20. This is the CD5. And you can see here what I mean by the variation between the weak staining and the strong staining. So here we've got residual T cells, and here we've got all this background staining, which is a bit weaker. But this is the really critical immuno. Obviously, it's nuclear, So that kind of gives it away. This is cyclin D1. So this is obviously positive. So this looks like a mantle cell lymphoma. And it's unusual because it's got some large cells in it. Yeah, so we're gonna we don't do that in our hospital, but our sister hospital we do that. So we're doing a SOX11, we're doing a LEF1, and we've also activated a sample was taken for cytogenetics, and we're going to do the cytogenetics as well. Yeah. But I think this is a really interesting case because first of all, the patient has been given a diagnosis of CLL for a couple of years, and this looks like it's going to be mantle. And yes, it's got small cells, but it's also got occasional larger cells. So if you look at the WHO, it says that mainstream mantle cell cytology is characterized by small to medium cells with scanty cytoplasm and pleomorphic and blastoid variants. It's not pleomorphic or blastoid variant because they're tending all the cells tend to be larger. But it's characteristically, you know, mantle cell is usually all small cells. In other cases I've seen, if all the cells are small, it's more likely to be mantle. If you've got occasional larger cells, more likely to be CLL. This case, clearly, it's positive. This looks like a mantle cell lymphoma. Yep, they could be epithelioid histiocytes. You're right. So I haven't got a CD68, and it's very difficult on the cyclin D1 to say whether those large cells. I mean, it's just impossible to say on the cyclin D1 whether the large cells are positive or negative. I mean, what we have here is, that's obviously a large cell that's negative. That's a large cell that's negative. These are large cells that's negative. So CLL can undergo transformation to Hodgkin's. Are those large cells CD20 and CD5 positive? So the large cells, if we look at the large cells, let's go for CD5. Well, that's probably an easier marker to look at. So I mean, with these, yeah, I think they are. Yeah, they are. I mean, this got some larger cells here. I think they are positive for CD5. I mean, it could be mantle cell that's undergoing, focal transformation with occasional larger cells. We've also asked for a Ki67 to see if that's increased. I mean, but if this is the case, then it's been suboptimally treated for a couple of years. Those larger cells look to be negative for CD20. Negative for CD20. So it's going to be a complex case, really. We'll see what the SOX11 and LEF1 show, and we'll see what the cytogenetics shows. But it looks to be mantle cell rather than CLL. Okay, I think we might have time for one more case from the BLPG set. Case 4. We'll go to case 4 because case 4 is... okay, so in pleomorphic or blastic variants, you don't get to see a transformation. So diffuse, yeah, that's usually the case, Yusuf. So usually when you get a pleomorphic or blastic mantle, the ones that I've seen, they're all blasts. It's not just focal blasts, and it's not. And I haven't. Whereas in follicular, I've not infrequently seen both remaining follicular and sheets of blasts equating to transformation, and I've seen it in CLL. In mantle cell, in the blastic variant, I've usually just seen blasts and not any residual previous mantle cell. Though the cases I've seen of blastic mantle cell have all had, or pretty well, almost all had prior diagnosis of normal mantle cell. Yeah. So we'll go back to stop that share and do one last case. I've not done as many cases as I thought, but hopefully that's been useful. So this one, we're looking at a 36-year-old male with a level 5 lymph node, and this is his lymph node. And this one, small biopsy, ignore that. And I think you can almost make the diagnosis just, you can't see it at that power actually. You can see it at this power if you look carefully. Any ideas what this might be? No normal architecture, very difficult to see normal architecture on a node anyway, on a needle core anyway. Any idea what's going on here? Follicular, great. Yes, so you can see at low power these follicular areas, and then it's just a matter of looking in to them to see have we got the appropriate cells. So I think there's going to be grade 1 because most of the cells are small to medium. We've got some lymphocytes and we've got these large numbers of these elongated cells which are slightly grooved. I always think they look like that. Yeah. I always think they look like scrunched up bits of paper. So they've got a long axis and they've got little folds in them. And that's how I think of centrocytes, elongated with folds along the nuclei, like scrunched up bits of paper. I've got a very simple mind. So that's the way. So I look for that in these. I look to see, have we got cells with a long axis? Yes. Have some of them got little grooves in them? Yes. They're probably centrocytes. Have we got some large cells? Well, we've got that one there, that one there. We may have others in the other follicles. Yeah. Not as many centroblasts as usual, actually. The immunos were quite strongly supportive. So we've got CD20, strongly positive. CD10. So CD10 is positive both within the follicles, but also importantly, CD10 in follicular lymphoma and not in normal reactive follicles, but in follicular lymphoma, CD10 spreads out into the interfollicular zones. So if you see CD10 in the interfollicular zones like this, it's going to be follicular lymphoma rather than reactive follicular hyperplasia, because obviously normal reactive follicles will also be positive for CD10, and they're positive for BCL2. So a combination of CD10, CD20, and BCL2 is always follicular. Though you could probably do it, in fact, on the basis of the CD20 and the CD10, because you're seeing the CD20 in the interfollicular zones, which is not normal, because CD10 is a follicular marker. So in a normal node, I don't know if they haven't given the control here. I'm not sure if we can find one in let's see if we can see one in Hibber's set of reactive lymphadenopathies. So she got a reactive node. Actually got CD10 in a reactive node. Yes. Yeah. So you see here, okay, it's tonsil, but anyway, CD10 completely restricted to the follicles. So this is follicular lymphoma, and I think it's grade 1. Okay, Pillar has got a question. Could you please tell me which differential I should consist in a mixture of cellularity Hodgkin lymphoma, whose flow cytometry? Most common infections have been excluded in microbiology. So this is a case you've got, Pillar, is it? Mixed cellularity Hodgkin's. Okay, so mixed cellularity Hodgkin's tends to have relatively large numbers of classical Hodgkin cells, including Reed-Sternberg cells. And I think that's the main feature of mixed cellularity Hodgkin's is relatively easily identifiable Reed-Sternberg cells. Differential, probably not a great differential for mixed cellularity Hodgkin's with classical features. I'm not sure I can help you much more on that question. I hope that was helpful. Probably not entirely helpful. Okay, we've only done 4 of the 8 cases in this set. So given that this is the audience I've started with today, let me just bring up the audience list again if I can find it. It's very difficult to navigate around everything. You have to have multiple screens open to share things as well. I'm trying to find the participant list. It seems to have... There we are. Great. Okay. So next week is going to be Ali Winstanley on hepatocellular tumors. So please share the link liberally with your colleagues. The week after, I will return to Hempath, and I can either carry on with this EQA set. There are another 4 cases in the set, or I can go back to Trefines, or I can look at a general EQA, which I recently did as well, which is also educational. So of those 3 options, we'll say option 1 is carry on to finish this set. Option 2 is for me to do back to Trefines. And option 3 is for me to do a general histopathology EQA set with a whole range of different types of tumor in it. Do people want to vote on the chat, please? 1, 2, and 3, and we'll see which one I'm going to do. So 1 is finish this set, 2 is back to Trefines, 3 is general EQA. So we got 2 votes for option 1, which is finish this set, 3 for that. Someone wants to go back to Trefines. So what I'll do is this, the next, the remaining 4 in this EQA set actually is 2 lymph nodes and 2 Trefines. So what we'll do is we will go with this lymph node, we'll go with this EQA set, finish it off. We'll have a couple of Trefines in there as well. And then I will fill out the time as required with other additional Trefines from our practice as usual. In terms of the EQA, we have coming up just, I know we're on the hour, and I'm conscious of Ava's time in particular because and I know that you've all got things to go to. But I want to look very quickly because there's an EQA discussion meeting that we have. And it is on the 27th of November. So the 27th of November, that's actually me. Looks like, yeah. So that day, I can move I may be able to move the teaching for people to join the Northwest EQA discussion. And then we can go through the Northwest EQA set. So looking at my timetable next week, next time I'm on, which is not next week, but a fortnight from now, I will continue this set as people have requested. And that'll be on the 26th of November. And then on the 10th of December, I will go through the EQA set. Yeah, because we would have had the EQA meeting. And I will send out via this group an invitation for everyone to attend the EQA discussion group if they wish. And there's a lecture as part of that. It'll be at a separate time to this normal teaching, but people from abroad. I have had permission in the past for people to join, so we'll activate that again this time. And then we can go through that EQA ourselves on the 10th of December. Yeah, because it's a very instructive case and it only comes up every 6 months. Okay. The recordings, so the recordings of these will be sent out to everyone who is registered on the list. So anyone who is on this, I believe, Ava, do people only get the recordings if they've attended the actual webinar, or do they get recordings if they've missed one in between and they're on the list?
I can send it out to all of the attendees for this specific one, but if someone that didn't attend wants to reach out to me, I can send them any recordings.
Okay, so we'll just put Ava's email in here. So it's, oh, Ava, if you want to type it in, then we get it right. You just type your email in, and then anyone who has missed a recording, they can ask you to send it. There you are. Yeah. Just want to, it's just my spelling of Deciphex. Remarkably, none of you will believe this probably, but I couldn't actually read or write till I was 10. Uh, so I still struggle with precise spelling of words, and I didn't want to get the E's and the I's wrong in Deciphex and send you all to the wrong place. So December the 26th. So each week, so someone's asked about December the 26th. I don't think we'll have any teaching on December the 26th because that's Boxing Day. I'll be on holiday 26th. Yeah, we will have teaching on the 24th, November the 8th. November the 8th? Sorry. So the next teaching will be next week, which will be November the 19th. But the same, Ava is going to be sending out a new link, but everyone will just however you access the link, whether it's through the WhatsApp Histo Club or through the email circulation that Ava sends out, the link that is sent out next week for next week's meeting on the 19th of November will be the link to use. So we'll be changing from a Zoom platform to a new platform next week on the 19th of November. But all any of you need to do is just click on the link that Ava will send out for next week and it will activate immediately. Yeah. Is that okay, Ava?
Yes, definitely.
Yeah. So from all of you who are joining, it should be the same. Just click on the button. But if you use if you use the old link thinking it's recurring, the recurrence will stop from this week because we're moving to a new platform. But it will work the same as Zoom as far as you're concerned, and all other functionality will be the same. Recordings will continue to be sent out to you afterwards. All you'll do is you'll get it each week as usual. Here's the reminder, there's the meeting, here's the link, click it, and that's it. But if you use an old link, it will just take you to somewhere blank. That's all. So new link, but it will be sent out to you all. So hopefully that will all be fine. And Ava's put her email in again kindly if there's any problems. I know we have run over now, so I know for some of you it's very late, and I know you all have many other things to do, including Ava in particular. Thank you very much for your time. I look forward to seeing you all next week with Dr. Ali Winstanley. Thank you.